Okay. So let's see. Today is Thursday. Next Tuesday is movie day, just on Zoom. So there's no in class next Tuesday. Then when we come back from break, we're going to have two speakers, and the speakers, on Tuesday and Thursday, and that they're going to be talking about international health. But both of them want to do it on Zoom. So we'll basically, there's no sense in us coming in here and then just zooming in with them. So we'll do Zoom on Tuesday and Thursday. Then the following week, we have a review session and then the final. And the final will be in here. So it'll be the same format as last time. 35 multiple choice questions. You can bring a one-page sheet. I'll give you a study guide, probably, the Sunday after Thanksgiving, I'll probably put it online. Any questions about the final, or, basically it means that we probably won't meet from here again until the final time. Everything else will be on Zoom from here on out. So anything else, anything that you want to ask before, given our last day together in person? Any other questions about finals or anything? Okay. So what we'll do is we'll finish up today talking about, well, first off, there's assignment 5 that's now online. So you have assignment 4. I extended the deadline of assignment 4 to the 28th, so the Tuesday after Thanksgiving. Then this one is due on the following Tuesday, but you can turn it in whenever you want. As you can see, it's pretty simple. It's just going through and sort of saying, take the question that you did in assignment 1 and then answer it, how you would answer that question. And then the second part of it is that, suppose you sat down at Thanksgiving dinner with someone from your family and says, what's the most surprising thing you learned? So just, in a paragraph or so, just tell me what it is that you found the most surprising. And then there's extra credit if you want to do it. It's optional, not required. So what I'm looking for you to do is basically go on ChatGPT and see how they would answer your question. Now you may have to, I'm not sure, has anyone here been on ChatGPT? Yeah. So you have to, you may have to play with it a little bit. First off, it's fairly simple to get on, right? You have to, there's a, I think you have to register for it, but you can either pay for it or not pay for it. I would suggest at this stage not paying for it. You can just go on and do that. Just go and do the free version. And you may have to play around with the question a little bit, because if your question is awkwardly worded, then it may answer some other question. But if you want to do it, then just do a 500-word essay just to see how it is that they answer your question. Good. Okay, now remember that's optional, so you don't have to do that. And that's due on the 5th. What I'll probably do is I'll probably extend the deadline of this until after, till the 12th after the final. So if people look like they're getting kind of slammed, then I'll probably, if I get a request, I'll go ahead and do it. I'll just make it do it at the 12th instead. All right. Any questions about this assignment? So you have 2 assignments due. One's due on the 28th. The other one's due right now on the 5th, just to get you to get it in. So what we're going to do today is finish up talking about pharmaceuticals, and then I'll talk a little bit, if we have time, I'll talk a little bit about, to give you kind of an intro to thinking about international, how to compare, or how to think about other types of healthcare systems. So last time we were kind of going through the evidence for direct-to-consumer advertising. And so the issue here is, the evidence against direct-to-consumer advertising. So we went through that last time. And so that was here. 1 is that it's not informative. 2 is medicalization. So make sure you understand what medicalization means, because that's kind of a big deal when it comes to pharmaceuticals. Any questions about medicalization? What it means, or Okay. Come back. Then we said that there's the criticism that drives up spending. And the idea here is that, well, if people come in and are asking for different types of medications, is that they don't need, is that just going to lead to unnecessary kind of spending. And also that it shifts it from generic drugs to high-cost drugs, because the drugs that advertise are basically our brand drugs. And so people come in to ask for the brand drug. And so the idea is that it raises prices. So now what we're going to do is basically go through the evidence for direct-to-consumer advertising. So this is the argument that sort of says, why is it that you should be allowed to advertise? So first is this idea that, well, anything all these attempts to try to sort of say that you shouldn't be able to advertise for pharmaceuticals is what you might call anti-paternalistic or paternalistic. The idea being is that, well, people can make decisions about what it is that's kind of true and not true. And so they can go through that, they can make decisions about, they're not naive and gullible and such. And also is that doctors are not these perfect agents of patients. So remember, the idea against, that medical professionals usually have against direct-to-consumer advertising is they say, oh, well, we're the agents, says the doctors, we're the agents. And so people are going to be coming in and asking for things that they don't need. And so it's going to take up all our time, et cetera. So there's this basic assumption is that, well, these doctors are these perfect agents of individuals, when, in reality, doctors aren't perfect agents. First off, there's a lot of money that's spent on direct-to-doctor advertising, and it has an influence. That's a bit troubling. Also is that, there's oftentimes, doctors will give advice that's not right. And the idea is that, well, people aren't stupid, right? They can see what they trust and what they don't trust. So like this is a survey that was done to sort of see how much do people trust what their GP said. And basically about 58% of people trusted what their GP said, about 8% didn't trust. And then when it got down to newspaper advertisements, it was, basically 1% said they trusted the newspaper advertisement, 28% said they didn't trust it. So the idea being is that just because something's an advertisement doesn't mean that people are going to fall for it. The second sort of argument for it is it says, well, what it does is it gets people who are in poor health to talk to their doctor. So this is especially true. Remember, there's different types of advertisements. There's one where they advertise the drug. And then there's the other one where they advertise just about the condition. So they say, diabetes is a serious condition. And so, the idea being, the argument for it being is that, well, that's an informative type of information, because if somebody doesn't understand what they have and they sort of see the symptoms there, that then, they're going to go through that, they'll be more likely to go and get healthcare for it. So there's this idea that, well, it's not necessarily bad that people are being informed about different things and asking their doctors about it. Also, there's the safeguard in that, it's not, these are all pharmaceutical, these are prescription drugs that are being advertised. So it's not like that they can just go through and buy them on their own. All that these advertisements are doing is basically just telling people that they have to, that they should go and ask their doctor if this drug is right for them. Third thing is that, well, it sort of says that the only reason, in fact, it works. So not only are doctors not your perfect agents, but direct-to-consumer advertising works because there's problems in the doctor-patient relationship. So that, that if they, when they go through and they look at different type of studies to sort of see, well, how much are doctors sort of misdiagnosing or things like that, is that the numbers are pretty high. And so this is the view of drug companies. So drug companies will basically say that, that it's not, that what they're trying to do is that they're trying to help patients by making them understand better what their conditions are. And it's because the healthcare system is not necessarily, seeing everyone as often as they should, and that people aren't getting regular checkups and things like that. So therefore, this is a necessary thing. Number 4 is that provides information. And so, they point out that actually to all groups. And so, the point here being is that one of the criticisms of banning it is that you think, well, who's going to get information about different types of drugs and conditions? Well, it's going to be people who go to the doctor and people who are basically have other types of means of getting information, such as the internet or things like that. So the point being is that, well, if you ban direct-to-consumer advertisement on televisions, or that you're not necessarily going to mean that people can't get information on the drugs. It just means that not everyone can get information on the drugs. And then the 5th thing is that, well, there's nothing really wrong with medicalization. So there's been studies that have gone through and looked at kind of the different types of effects of pharmaceuticals. And they find that, when they look across countries, I know the numbers are small, but you can look at them yourself. When they look across countries, what they see is that, well, there's actually, people who are on medications have better health outcomes than people who aren't on medications. So, there's not really much, you would expect that if medicalization was truly just making up different types of conditions that they're going to give worthless drugs to, is that you wouldn't see any benefit in terms of life expectancy or health or anything else. But because there is benefit, it suggests that, well, it's not, they are treating real health conditions. Okay, so, that's the arguments for and against direct-to-consumer advertisement. There is this, I think that the conclusion being is that around the world is most places don't allow direct-to-consumer advertisement. In the US, it's kind of been something for which it's now, there's not that much debate about it at this point. I don't think that if you look at what the FDA does, that they require all the different types of information about all the horrible side effects that can have, and that kind of, I think, cools people's enthusiasm for drugs. At the same time, I think the critics are sort of assuaged because they sort of think, well, at least people are getting all the information. But this came up just more recently when there was when the FDA tried to allow warning labels on cigarettes. So if you look at a cigarette pack, right, it says things like, cigarettes can cause cancer, and it has all this. Well, in other countries, they do things like this. They have on their cigarette packages, they have very, very graphic type of displays like that. So this is what the FDA tried to do, is that they tried to sort of allow public health to kind of come through and put these type and require that cigarette companies put these type of graphic displays on them. And so the cigarette companies, they went to court and they said, no, you can't force us to do this. And the FDA said, well, we can enforce packaging. So we can go through and that we can, kind of say there has to be warning labels. And the cigarette company said, well, this is not providing information. So therefore, you can't, it's violating their free speech because you're making them do something. So what do you think? Should cigarette companies be made to put on these type of graphic warning on their cigarette boxes? Does it, because the rationale is that, well, this is the consequences of smoking, so it's providing information about the consequences of smoking. So give me show of thumbs. How many say yes? The cigarette company should be required to put this type of information on there versus no, cigarette companies should not. So I see all. How about McDonald's? Should McDonald's, if the FDA came through and said to McDonald's, well, your hamburgers are causing obesity, and which causes diabetes. So therefore, we want to go through and show, we're going to require that on all your Big Macs, you have a picture of a diabetic foot that's been amputated. Agree? How many would say yes, that's fine, versus no, that's not fine? Okay, yeah. Yeah. So you think that they should? They should be allowed.
Yes, if you're gonna do it to one of them, do it to all, because there's already got a lot.
Okay, so let's say, so is eating McDonald's healthy? No, so therefore, should we allow, should we be, should they be forced to put on things like this? Yes or no? Yes or no? You can't go halfway. You have to say, yes, they should be, or no, they shouldn't be. No, why not?
I feel like as adults, people can make their own choices, and yeah, even though some of those choices are bad, like smoking and things like that. They are adults and they do have free will. And it's like, yeah, the company should give some type of discretion that, yeah, these products are bad. But at the end of the day, I feel like people should be free to make their own choices that way.
Okay, so you think, so you're saying is that, well, look, at people are adults, and so that they know that. On the other, should cigarette companies be required to put the little thing on there that says that cigarette smoking can cause cancer? I'm gonna say yes or no. Say yes, they should be allowed, they should be forced to put on the little label that says it causes cancer versus no, they shouldn't. Okay, so you say yes to that. Does that violate their free speech? I mean, is that because that's the argument, right? That this is for, I mean, the government doesn't do this with other things. They don't come through to Toyota and say, Toyota, on your advertisements, you have to show pictures of car crashes with, bloody bodies laying on the pavement. They don't do this with other things. So what's the rationale for why you would do, when would you do it versus when would you kind of not do it? Well, it seems to be if it's information enough. So the question is, does this provide, I mean, so the label, the argument for the label is that the label provides information. So therefore, it's kind of okay to go through and to require that they do that because, it's information. Same thing for alcohol. Alcohol, little packages says that pregnant women should not, that risk of fetal alcohol syndrome if they drink alcohol and things like that, right? So those are all seen as information things. So the question is, well, does this provide information or does it just sort of, is it just aversive? So, if you think about the other, imagine that the FDA came through and said, every time that someone touches a cigarette package, they should get an electric shock. Right? That would be aversive, wouldn't be information. And so this is aversive. And the question is this information? Well, the FDA said no. And that's kind of stuck with that going through at the current situation is that, well, the FDA has kind of backed off on doing this because even though there's been studies that have come out that sort of says, well, actually, these things do provide information and that people's knowledge increases. If you make it more salient, then people's knowledge increases. It hasn't led to a reversal of it. Okay. Last thing about drugs then. So, as I mentioned in the Inflation Reduction Act of 2022, one thing that it did, it allowed Medicare, to negotiate drug prices. So this was for the first time, Medicare had been banned for doing that since Medicare came into existence, and especially they were banned for doing it from 2006 when Medicare Part D was enacted. So, but now they can't. So the question is, well, so what's going to happen, right? What's going to happen when they can negotiate drugs? So the legislation basically said these things, right? That negotiate pharmaceuticals that meet the criteria. Small molecule drugs approved 7 or more years. Biologic approved 11 more years ago. Why is that significant? Why is the 7 or more years or 11 more years significant? Yeah.
More related to this and also the new bond study.
So like what's the period of time that drug companies really care about? Well, it's what their patent is, right? What's the patent? How many years is a patent? 20? So basically what this is saying is that Medicare can't come through and a new drug that comes on the market, like take the COVID vaccine. It's like they're not able to go through and negotiate the COVID vaccine because the COVID vaccine came in less than 7 years ago. So it sort of says that, well, you can only do things that are, 7 or more years. So basically they've given them a run of being able to get their profits back off of their development costs, right? By being able to just sort of charge higher prices. So it said that, so Medicare had said there are going to be 10 drugs in the first year and then increase it to 20 drugs after that. And the first 10 drugs are going to be listed in September 2023, and they were, with the prices going into effect in 2026. So it's not happening immediately, but it is kind of occurring. And then drugs under Part B will be negotiated in 2026 and go into effect in 2028. So this led to some speculation about, well, what would Medicare do, right? So these were the 10 drugs that were kind of initially thought were going to be the ones that they might target. So the reason is because, like, here's in this column, this third column, it says Medicare Part D spending. So this is how much they were spending on each of these different types of drugs. And then over here is the number of beneficiaries, 2.6 million people. And then on this last column is the year that it was approved. So all these things are more than 7 years old, just like they have to be, or 11 years old, depending on the drug. And then they have a certain type of generic name, which means that that's essentially the formula. And so the thought was that they were going to go for these types of anticoagulants, like warfarin and things like that. Diabetes treatments, oral cancer drugs, inhalers for asthma, and then anti-inflammatory ones. So, what does this mean? Why are they picking these ones? Well, what they were doing is that the legislation said that the Health and Human Services was supposed to look at the comparative effectiveness of treatments. So I think I mentioned this briefly, but back in when the Affordable Care Act was coming through, is that one thing that the Obama administration did is they started the CORI. The CORI is the Patient Outcome something research center. It's essentially, it's like a quasi body within the government that looks at different patient-centered outcomes. And that what that means is that they fund studies that compare how effective things are in actuality. So what they're basically trying to do then is they're trying to target drugs for which there are other types of conditions, other types of treatments that might give the same or not that different outcomes. So what they're not trying to target then drugs for which it's going to be, I don't know, the hepatitis C drug, for which there's not really there's no real alternative to the drug treatment. Those aren't the ones they're going to do. They're going to target things for which there are other types of either drugs on the market that are similar, or that there's generic drugs on the market that do something similar, or that there's other types of treatments. So like if you think about if you look at this thing, anticoagulants, right? Lots of different types of anticoagulants on the market. Diabetes treatments. Well, they have diabetes treatments here, but there are also different types of ways that you can treat diabetes. So what they've done is that it's basically saying to them, go look around and see what make sure that when you go doing something, you're looking at the relative effectiveness of drugs. The other thing is that they focus on these sort of the short and extended long monopoly drugs. So that short monopoly are drugs that are 11 years or fewer. Extended monopoly are drugs that are 12 to 15 years past approval, and then long monopoly drugs are drugs that are almost off label. So almost the patent's almost off. All right, so these were the actual ones that were chosen by Medicare. This was just announced. These 10 drugs. I have no idea what any of these drugs do. I'm sort of reading about it, can kind of get a sense about what they were trying to do with this, but other than that, it's we'll have to wait and see. All right, so what type of impact is this going to have? Well, just remember that the issue is that to date, that Medicare has pretty much just paid whatever the drug companies kind of charge. In essence, they were paying the average cost rather than the marginal cost, the production cost. So in theory, this is going to allow Medicare to basically damp down on the price by going through and getting closer to marginal costs. Will it actually do this? Well, there's a reason to be skeptical. One is that in drug companies pay a lot of money to politicians, and so it's part of the reason why this has been slow to be enacted in all these different years is because drug companies would go through and say, well, look, if you do this too aggressively, then we'll just pull all of our research development out of the US and go to Europe or go someplace else. But then more generally is that, well, there are ways that you can go through and that you can negotiate. So for example, the way that other countries do it is that they go through and that they use the market power to essentially as the way to negotiate prices. So I'll give you an example. There are various drug companies, drug agencies around that do this for government. So Pharma is the one in New Zealand, but there's the Pharmaceutical Benefits Review in Australia, and there's NICE in the UK, and there's, what's it called, Quibi in Germany. And so most countries have this type of agency that does this type of negotiation. And so in a country like New Zealand, what they do is that they basically have, for medications, they'll have 3 different types of categories of medication. They have those that are on schedule, there are those that are off schedule, and those that are not allowed. So what that means is that on schedule means that when you go into a pharmacy, all you pay is $15 copayment. Regardless, it doesn't matter how much the drug costs, is that you pay $15 and then the government pays the rest. So that's an on schedule. An off schedule means that you can go in the pharmacy and that, if you want a prescription of some drug that the government's not going to subsidize, is that you can do it, but you pay the full amount. So rather than paying the $15, you might pay $100 or $200. And then finally, they just, for some drugs, what they do is they just say, well, we're not going to allow just drug company to sell this drug in here. We're only going to allow, only going to allow this drug, Gilead to sell the drug, and not Merck can't sell their anticoagulant. And so it means that some drug companies can't go in and actually just sell the drugs in New Zealand. So what they do then is that they use the fact that they can control the number of people who are going to buy that drug, who are going to use that drug to negotiate prices. So suppose you had 2 drugs, right? You had this anticoagulant and a hepatitis C drug. And that the anticoagulants are ones where they sell a whole bunch of it. And the hepatitis C drug is one that is very expensive, but also very rare. So suppose, I just made these numbers up. Suppose that it was $50 per treatment for the anticoagulant, and there's 5 million treatments per year. And so the total revenue is about $250 million. Now for the hepatitis C drug, assume it sells for $1,000 and 10,000 treatments per year. So it'd be basically $100 million. So if you look at these 2 drugs, you would say, well, the total amount that's going to be spent on it is $350 million. And suppose that there are just, there's only 2 companies, and those 2 companies split the market so that they each sell, so that company A sells 50 at $50, and they sell, they 250,000 treatments. And so basically they're making $125 million on this. Same with company B, and they both make $50 million. They split the market on hepatitis C, so they make the same amount there. And so their total revenue is basically, they're just splitting the revenue. Okay, so just imagine you have 2 companies. Well, what they can do, what governments do, is that they go to to one company and they say, okay, company A, we're willing to let you be the only company that can sell anticoagulants in the country. But you have to give us a better price on your anticoagulants. So if they did that, they would say, okay, company A says, all right, fine, we'll reduce our price of anticoagulants $50 on $40, and we'll reduce our hepatitis C drug from $1,000 to $750. And company B says, well, we're going to keep our anticoagulant price the same, but we'll reduce heavily our hepatitis C drug. And so then what the government does is looks and says, all right, so under which of these different things are we going to spend more and which are we going to spend less? So in this case, if they did that, if A got all the rights, they would end up spending about $275 million a year. And if B got all the rights, they would still spend $300 million a year. So they would say to A, okay, A, you get, company A, you get the entire market. So what they're doing is that they've gotten a lower price by excluding company, making it so company B can't sell the drug in the country. Now, as you can imagine, so let's take Medicare then. What this means for Medicare is that if there's two companies, Merck and Gilead, and they both sell some type of common drug like an anticoagulant, is that what they would say to companies is, okay, give us your best price. And that the company with the best price, what we're going to do is we're going to only allow only subsidize our patients, our Medicare patients on your drug, and we're not going to subsidize on the other drug. So that means that people could still buy the other drug, but they would just have to pay full price. Drug companies like this? No, drug companies hate this. Drug companies in countries around the world, what they do is that they basically always threaten that they're going to pull out and not sell any more drugs in the market if the country gets too aggressive in terms of their negotiations. They're willing to do it, and they've been willing to do it in small countries like New Zealand and Germany and things like this, where they're big markets but not huge markets. But the U.S. is a gigantic market. So are they going to go through and allow, basically, how will they push back on the U.S.? So the question is, how big of an impact it's going to have in the U.S. is how aggressive Medicare wants to be. If Medicare just negotiates small price differences, then the drug and allows different drug companies to get different shares of the market, then they'll probably say fine. But then you're not really going to, it's not really going to save much money. On the other hand, if Medicare comes through and gets really aggressive with their pricing, then what you'll see is you'll suddenly see politicians start to scream, because what they'll say, our patients are, my constituents are coming to me, and they're telling me is that, that the Merck drug is actually the best for them, and yet, their Medicare is not allowing them to have it. Instead, they're being forced to use this other Gilead drug that's not as good. So so if Medicare becomes too aggressive, then that's what's going to come down the road. You'll start to hear the cries come out that essentially is that they're restricting choice. All right, so that's why jury's out in terms of whether this whether Medicare is going to be able to actually bring down prices a lot. And I think it's important because if you look at when they're starting to look at ways of reducing the budget or balancing the budget, like for example, Biden had a couple months ago when the budget negotiations were first starting, he came out with a plan, and that in this plan he had tremendous savings that were going to come from healthcare, and most of it came from negotiating Medicare prices. And so if that's true, then that means that they're going to get really aggressive about it, in which case then drug companies aren't going to be very happy. And you can expect that to start to hear people complain about it. On the other hand, if they're not very aggressive about it, then they're not going to save much money. So it's a bind. All right, so that is drugs. Any questions about drugs and pharmaceuticals? Okay, last topic we're going to cover in class is international health, is health in other countries. So the reason why the focus on healthcare in other countries is because every country is kind of set up their healthcare system a little bit differently, and yet they all kind of face, and so they all face problems. So there's no perfect type of healthcare system in the world. But the type of system you have kind of determines what kind of problem you're going to end up having. So like in our system here, we have problems with poor access, and we have problems with high cost. Some problems with quality of care too, but not some, compared to other countries, it's not that different. But it's really high cost and poor access, meaning that there's a lot of people who don't get healthcare and that or only get the very basic things, and that it's really, really expensive. In other countries, like if you go to the UK, they'll talk about the politicians talk about the cost of the healthcare system, but people don't usually talk about that much, as the population doesn't see it, because healthcare is pretty much free. So in the UK, the thing that they have is that they have questions about quality of care, and especially about waiting times, like how long it takes to get care. Same thing in Canada. Canada, if you listen to some of the things on the Canadian system, that what they'll say is that, oh, Canada has such long wait times. And so that's typically what you see. You see countries that have more universal type of healthcare systems, their problems are wait times. And the US, which is about the only country that has a kind of market type system, is that the problem here is not wait times, but the problem here is just access and cost. So what I want to do is give you a framework to think about how you go through and think about different healthcare in different types of countries. All right, so if you remember way back when the course started, we talked about there being 4 different types of healthcare systems. I'm going to expand it a little bit, because now we want to talk about not only about about sort of the structure in terms of who pays for healthcare, but also whether the providers are private providers, or if the private providers are paid for by the government. So we talked about like an out-of-pocket system like India. And so in India, healthcare providers like hospitals and doctors are private, right? They're not paid for by the government. In the US, for the most part, if you have employer-based insurance, then you go through and you use Mercy, that's a private provider. Golden Valley is a private provider. All the different type of healthcare that we use are all private providers, unless you're in the Indian healthcare service, or if you're in the veterans healthcare. For Canada, they all have private providers, meaning is that if you go to Canada, the doctors and the hospitals are all private. They're usually nonprofit, but still they're private providers. And then the last one is the UK, and the UK is primarily a government-run type of healthcare system, meaning that hospitals the major hospitals are run by the government. Primary care tends to be private in the sense that doctors are, they're not on salary from the government, but they're reimbursed from the government, and so they're pretty close to being government employees. So the general framework I want you to kind of think about is this thing where you separate out the people, that's us, from the one who funds healthcare, from the one who purchases healthcare, from the providers. And so the basic type of framework is that, well, the population, they get healthcare either by just having, paying user charges to provider, or they pay it by some type of taxes or contributions or something to a funder. And that then there's someone who actually purchases the healthcare, and that purchasing then, and they purchase it from providers, and then the providers, they provide the healthcare to people. So the simplest way to think about this is the private is an out-of-pocket like India, right? So this is the model that exists for buying hamburgers, right? Buying hamburgers, you have McDonald's, there's the provider, you have us, as the people who buy hamburgers. And what happens is that we go into McDonald's and we look at it and we say, okay, I want these hamburgers or this, and they say, okay, and they provide us with those hamburgers. So there's no government agency that comes in and says, oh, well, we're going to, fund your hamburger purchasing from McDonald's for you. It's not like you can just walk into McDonald's and get all the hamburgers you want and the government will pay for it. It's just it's a regular private, it's a regular type of market interaction. Well, the key features about this is that, well, there's no real role for government at this point to come in. The providers are all independent and people are funding it independent of it. But there's also in this type of system, there's no equity, right? Essentially, if you've got money, then you get healthcare. And if you don't have money, then you don't get healthcare. So the problem with this type of system tends to be, you don't have problems that exist from the government having to try to regulate it. But what you do have is you have the problem of equity, where that people without healthcare, without money, don't get healthcare. The second type is the private insurance type model, right? Which is kind of what we have in the US. There's a couple different types of this. So one is the, what most people have is that we get insurance. In fact, you could actually, for a lot of people, what they do is that we, work for a company and it's actually the company that pays for part of our insurance. So we pay part of it, the company pays part of it, but somehow the insurance company gets the money. Then the insurance company then, they either have some type of association with providers or they don't. You can have an insurance type health insurance policy where you can choose your provider, right? You can just go through and then you can go to any provider you want and the insurance company will just pay for it. That's usually a really, really expensive type of healthcare plan. So, and I don't think like at the UC they offer that anymore, but it used to be fairly common that you could pay a lot of money and that you would have a plan whereby you could just pick whatever hospital you wanted, you could pick whatever doctor you wanted, the insurance company would pay for it. Travel insurance, so in that case, then this doesn't exist, right? There's no relationship here. You then go to the provider provides you services, you send a bill to the insurance company, and the insurance company then pays the provider. Travel insurance kind of works this way. Like if you ever get travel insurance and when you go overseas, the way travel insurance typically works is that if you have to go to the hospital, is you go to the hospital and you pay for it. And then when you get, then you submit a bill to your travel insurance company and they reimburse you. So in that case, they don't actually even pay the providers, you pay the providers. So you can see is that's a kind of a risky type model to do that. Because if you go through and pay and that then your insurance company says, no, we're not going to pay that. Like a friend of mine, she went to Guam and that she was walking on the sidewalk, tripped and fell. She lives in New Zealand. Tripped and fell, banged up her knee, got taken to the American hospital there in Guam, in the emergency room, they treated her. And then as she's leaving, she was from New Zealand, so she wasn't quite used to having to pay for healthcare. As she's leaving, they said, oh, you owe us $9,000. So, she basically had to whip out the Visa card and pay $9,000. And then what she did is that she put in a reimbursement at the insurance company. Now the insurance company, they may have said, that's crazy. We're not going to pay $9,000 for this. And in that case, then they may have said that we're only going to pay $3,000. And so then they just reimburse her $3,000. And so then what does she do? Well, she could try and go back to the hospital and say, hey, how about if I pay you $3,000 instead of $9,000? But the hospital has their money, so they're not going to do that. So that's why this is a very risky type of thing. If you're on the type of insurance plan where you have to pay and then you get reimbursed, is that it puts you in the middle. Now, if they, the more common thing in the US then is that there's a relationship where the insurance company has a relationship with the providers. And so this is kind of where managed care plans come in, or in any type of insurance. So, if you think of Anthem Blue Cross, what Anthem Blue Cross has done is that they have an informal, they have a formal relationship with providers, whereby the providers will agree that these are the prices that we'll charge, our Anthem Blue Cross patients. And so as a result, Anthem says to the patients, if you want, as an Anthem, you can only see our providers. So that's a common type of relationship. It can also be more direct than that. It can be like a Kaiser, where Kaiser makes, basically puts the doctors on salary, and that, and so you can have a managed care plan that works this way. So it depends on how firm this line is here in terms of what kind of plan you have. Okay. The next type is what's called social insurance. So a social insurance plan, that's where, people pay sometimes contributions, but they also pay taxes, and the government pays into these sickness funds. So this is kind of what Germany has. So, I mean, I've talked about, I think I mentioned Germany as being a privately insured type of country like the US, and it's not quite true. It's a little bit more complicated, because what they do is that they have a sickness fund like this. And so people pay in money to this, it's like that, how we said there's the Social Security Trust Fund that sort of keeps money that's, separate from what the normal kind of government can spend. It's the same type of idea, is that they sort of keep a trust fund that money goes into. And so people, contribute to it. So you pay into this trust fund, but then people also go through that, is that they, the government can contribute. And so with that then, is that then, you go through that, you either do it through an insurance company, or you just directly, the sickness fund, basically you can get a sickness fund that pays for things. I mean, that pays directly to the providers. So there's different type of models, but the main thing is that there's this kind of other fund out there, which is the one that's dictating, that's actually doing the providing. So the reason, the key thing about this then is that in this case, the fund is both a provider and a purchaser of healthcare. And this became a problem as healthcare costs started to rise around the world, is that countries that have this type of arrangement, where you have money coming in and that they then pay providers, it started to be kind of a problem, because they wanted to make sure that they have to negotiate with the providers. So what a sickness fund does in this case, then, the sickness fund is actually the negotiator. Just like in the US, Anthem Blue Cross will try and negotiate with healthcare plans, with healthcare hospitals and things like that. Well, that's what this group does. This is kind of a government type group that negotiates with providers. In Germany, they also have like a whole bunch of other, rather than going to the sickness fund, you can have private insurance. The private insurance gets money and then does the same thing. But there's someone then who's negotiating with the providers and making sure that the providers aren't just sort of adding in other types of costs. Okay, so that's the basic idea of sickness funds. The next one is a national health insurance. So this is now where you have this is Canada, where essentially people pay to the government and then the government pays providers. So this is how Medicare works, right? Medi-Cal works, is that people, pay their taxes, and that then, that the government through, directly pays providers. So like if you think about how Medi-Cal works in Merced County, is that, the state gets the money. The state actually then pays the Alliance for Health, and the Alliance is actually the one who does the Medi-Cal purchasing. So why does the state do that, right? Why does the state come through and say, well, we're going to fund this company, the Alliance, to basically do this, rather than just the Department of Healthcare Services doing it. Department of Healthcare Services up in Sacramento, they could pay Medi-Cal providers, right? They don't have to go through this other company. So why do they do it? Well, the idea is that they're trying to get this other company to basically keep costs down. And so what they say is to this company, okay, through the Alliance, we're going to pay you a certain amount per person, and that you then have to pay for everything out of that money, out of that those funds. So you can't come through and come back to us and ask for more money later. If your costs go up, you lose money, then you lose money. On the other hand, if your costs go down and you can keep costs low, then you make money. And they can also, like, if this company, so that's the basic way it works. So you can see what the incentives are. The incentives here is that for this company is basically to come back to the next year and say, oh boy, things were really expensive last year. We just barely broke even. And so, next year when we negotiate our price per person, it's really going to have to go up. So what having a separate company does is allows the Department of Healthcare Services to basically say, well, fine, if you're not going to do it, we'll go to another medical purchaser and let them do it. So they're trying to create some type of competition between these medical purchasers. So, for example, the Alliance actually does Merced. The company that does the Alliance does Merced, San Benito County, and Monterey County. So, and the reason that they do all three of those is because they did Monterey, and then they bid to do San Benito and do Merced, and they came in with the lowest price. And so, Department of Healthcare Services gave it to them. But at the same time, the Department of Healthcare Services next year could turn around and say, forget it, we're going to pull our contract on that. So what they're trying to do then is they're trying to separate out the funder, in this case, Department of Healthcare Services, from the purchaser. In this case, the purchaser is the Medi-Cal purchaser. So they're trying to create like a split. And that's what, the beverage model is what the UK model is. So the UK model is that, people pay to the government, and the government then, basically has the providers, like they pay for the hospitals, right? They run the hospitals and they pay for it. Well, I know that, like, when I first started working down in New Zealand, and Auckland Hospital, which is the big hospital down there, they came out in the first year and said, we're $350 million in the hole, that they have a deficit of $350 million. And I thought, oh man, a deficit of $350 million, that means they're going to close down. Because if Mercy Hospital came through and said, we have a deficit of $350 million this year. Well, look what happened to Community Hospital down in Madeira, right? They started running a deficit. They couldn't get loans, so they closed down. So, hospitals in the US, they close down if they don't make money. Well, so that's what I thought was happening there. So I went to the doctor of my mill and I said, boy, big news, huh? That, Auckland Hospital may close soon. And he said, nah. He goes, this happens every year. He goes, because they know that Auckland Hospital is run by the government. So they know that the government's going to pay for it, right? What's the alternative? That they're going to close down the major hospital in the country. So they're not going to do that. And so there was like this, I don't want to say a game, but there's this back and forth that exists in countries like the UK between the government and the hospitals, where the government's trying to keep the hospitals from not spending too much. At the same time, they own them and they pay for it. So one thing that they do in these countries is that they create kind of other types of entities that are actually do the purchasing. So they'll create, like, what are they called in the UK? They're called not district purchasers, but they're like these regional, they're government offices, but they're the regional kind of purchasers. And what they do is that then they actually contract with the hospital. They own the hospital, but they contract with the hospital to basically for certain type of things. Like they'll say, well, we're going to contract for 50 heart replacements this year for this hospital. So the hospital then has to figure out, well, who do they give a heart replacement to? Beginning of the year, they know that they can only do 50 of them. And so they have to start figuring out, well, how are we going to prioritize this? So what happens if November comes and they've done their 50 heart replacements and that they have more patients who need them? Well, they could go back to the government and say, well, we've got another 5 patients who need heart replacements, but the government could sort of say, well, manager, you did a poor job. and so we're gonna fire you. And so managers get fired a lot who can't kind of manage that type of flow. So it's that, so governments, what they often do is they'll come through and then, they'll either give them a budget, say you have to keep it in this type of budget. Or what they do is they actually get down the same. You can do this many of these type of procedures, this many of those type of procedures. And then they let the hospital doctors groups and things figure out how they're going to prioritize it, how they're going to choose who to do. Do we have to do that? Does Mercy have to do that? Does Mercy have to sort of, what happens if a whole bunch of people come in and that they need knee surgeries into Mercy Hospital? What would Mercy Hospital do? Would they say, sorry, we're going to prioritize our knee surgeries? No, they would go, good news, we're going to go hire a new knee surgeon to come in. So, if all these people can pay for it, then they'll go ahead and they'll try and hire someone in. Or what they'll do is they'll contract with, they'll go down to Fresno, the community hospital, and say, hey, why don't you send your doctor up here twice a week for the next 3 months so we can do all these things and we'll split the money with you. So, in this type of system where people pay for it, is that you don't have that problem. They don't have to prioritize. But down there, where people don't have to pay for, your knee replacements, is that the government has to have some type of way of controlling what, how many knee surgeries they're going to do in a year. So that's the type of UK, that's the system that exists in those places. So even though the providers are oftentimes paid by the government, they're still seen as kind of, they try to set up these kind of false, these types of ways of trying to treat them as if they're still purchasing from them as a way of keeping down costs. Okay. So in these type of systems, then, if you turn around and say, well, who is it that's negatively affected by it, right? Well, in an out-of-pocket system, it's basically people who can't pay, right? People who have no health insurance or just people who can't pay. In a private insurance system, right, is that people with employer-based insurance are the ones who have to, are the ones who that's where if you want to get insurance in a private-based system like ours, that you basically have to have it through an employer-based system. In a social insurance market, right, then you're going to have people paying into the fund. So it's the fund that the sickness fund is actually the one who is doing all the negotiations. In a national health model, where like Canada, is that then again the government is responsible for it. And then in the UK model, it's the same thing. So point being, we have all these in our system. But other type of even in these other type of healthcare systems, is that oftentimes they don't just only have, like the UK doesn't only have this type of model. The UK also has private insurance. So you can get private insurance if you want in these types of countries. But typically what it is, it's called gap insurance. That is that it does things that the National Health Service won't do. So for example, a gap insurance could be if you are sick, if you get cancer in the UK, right, and you go down to the hospital, then you're going to get if they can do it, they have the capacity, and then they'll treat you in the national health system. So if you have something really serious in these type of systems, they tend to, you get moved to the front of the queue and they treat you. On the other hand, if you come in and let's say you have a knee that's achy and really bothering you, but it's not an emergency, it's an elective surgery. If you were in our system and you went down to Mercy and you said, I've got an achy knee, and they would say, well, let's see if your insurance pays for it. And if so, then they schedule you for a knee replacement. Well, in those countries, but they, like the UK, what happens is that if you have an acute need, is that then they may not, they only can do a certain number of knees a year. So they're not going to necessarily go through and put you to the top of the queue. That you may have a wait for. So what you can do if you want then is that you can go pay for it privately. As that you could go down to, there are private clinics. So you just go down to the private clinic and say, well, I'm willing to pay the 10,000 pounds or whatever it's going to take to get my knee replaced. And they'll do it for you. So, or you can buy insurance. And the insurance then would say, if you need a knee replacement, and if the public health system won't do it, then we'll go ahead and do it. So it's not insurance that covers everything. It's not like insurance here that covers all your health care. Instead, it's gap insurance because it's basically covering things that the National Health Service is not going to cover. Another thing that, like, for example, secondary, SEMA specialists. Oftentimes in public systems, the wait to see a specialist in the public system is really long. Like if it's not, cancer or something like that, the wait can be really long. So, if you've got, if you got something where it's not an emergency, that then you might have to wait a couple of months to see a specialist. But in a lot of these systems, you can also go and you can just see you can just go and pay to see a specialist out of pocket. So, pay $250 or whatever it's going to be to have a specialist appointment, and they'll see you the next day. So what it does is that they have these kind of ways around the system most of the time. Now, that's not true in Canada. Canada, they've set up their system so that they say to providers like doctors, if you're going to take money, if you're going to see the patients and be paid for by the Canadian government, that you can't just sort of take money from private insurance companies. That's it. If you take our money, if you want to be a private doctor and just work privately, you can do that. But then you're not going to see our patients. You're not going to see the majority of Canadian patients. If you see our patients, then you can't take private money. That's why when you hear about, like in Canada, in fact, you'll hear about this on Tuesday in the movie, people from Canada coming down and getting care, like in the US, driving across the border. The doctors on this side, they can provide services for people who come and are willing to pay for it. But the doctors on the other side of the border can't. So even if you come in there and say, here's my $10,000, I want my knee surgery, they can't do it. So Canada's an exception though. Most countries have some way out of this, where that you have some type of private, private pay-as-you-go type thing that you can do. But it's not for the really, really big things like cancer and heart transplants and things like that. That's not what it's for. It's just for things like knee replacements and other type of elective things, or it's for things like getting nicer rooms. So in these countries, they typically have private hospitals, and the private hospitals only then cover sort of certain type of a basic type of condition. So they don't cover, they're not going to do everything. But they give you like your own room. They'll give you better food and things like that. So if that's important to you, then you can buy private insurance and it will cover your stay in there. Or you can just pay for it out of pocket. But if you're in a private hospital in these countries, and let's say you go in there for your knee surgery, and that something happens, and that you suddenly have a complication, what they'll do is they'll put you on an ambulance and send you over to the public hospital, because the public hospital is the one that has all the best equipment. It's got the most staff, the most specialists that are in the public hospital, so that they don't, they're really just the private hospital, the private sector in these countries is really just something to do the amenities, do the gaps. But anything that's essential typically gets done in the public hospital. If you go to other countries that have more like Colombia, right? Colombia has a system whereby they have private insurance and they have private hospitals. And they also have a lot of people who are on a sort of a government type of healthcare plan that basically just pays for just some essential things is about it. Well, in those places is that there are private hospitals, but those private hospitals are not going to see the kind of the low income patients who would come in. Instead, there are other hospitals that those patients would go to. So in other countries, you do have that separation whereby the public hospitals become the primary hospitals and the private hospitals become the primary hospitals, and the public ones are then just for, for everyone else. That's kind of like what's like in Los Angeles. So, in Los Angeles, if you have disability insurance, which, through Medicare, which doesn't pay very much at all for reimbursements, is that, private hospitals aren't going to, they'll stabilize. If you come in there and you're bleeding, they'll stabilize you, but then they'll get you out of there as fast as possible. Because what they'll say, well, where do you live? And if you say, well, I live by USC, then they'll say, oh, then go down to Martin Luther King Hospital. Or if you live in Long Beach, they'll say, go to Memorial Hospital. Or depending on where you live, we'll send you to the kind of the more public hospital in that region to treat you, because they don't want to. In fact, they'll tell you, they'll say, oh, I'm sorry, we don't have any beds available. And it's not that they don't have any beds available. It's they don't have any beds available for patients who are only going to pay 30% of what private patients, private insurers pay. So that type of thing does happen all the time. That's a common thing that happens in the US as well. But that's because our public hospitals are not kind of the best hospitals, right? The best hospitals are, I don't know, Stanford Hospital, and these other ones that maybe they do a lot of care for low income, but they're primarily kind of high tech hospitals. Okay, so the point to note about these things is that in these countries then that have this type of universal systems is that waiting times are the primary problem. And so that's the reason is because if you think about, well, what is it that in those systems, what is it that's going to cause someone to, what's going to keep the number of people who want knee replacements down low. So, this gets into the needs versus wants discussion, because, like, for example, if I have an achy knee, do I need to have a knee replacement? Or let me ask it this way. What's the criteria that I would use to figure out whether I needed a knee replacement or whether I could get by with just, putting a brace on it and taking some painkillers? Yeah. Might say a bit louder. Well, I can pay for it. Yeah, I mean, but in these sense, where it's paid for when people aren't paid for it. And so someone else has to, basically the government has to decide who's going to get knee replacements. Right? What's the criteria to get a knee replacement? Yeah.
Coverage and the age, non-natural health condition. I think we have what we started like the one that another that other people need participation for the and then the non-coverage, right?
Yeah, I mean, you're coming up with reasonable criteria to use, but when it comes down to who actually is, who's going to make these criteria? Yeah. So you're thinking about coming up with an system for basically making this decision? Is that what you're thinking? I mean, it's like if I'm a doctor and I've got 5 patients, how do I decide? And I'm told I can't give them all the knee surgery. How do I decide which of the 5 I want to give knee surgery? I mean, you want these criteria. Yeah. And so what you're coming up with is basically this prioritization criteria. And so that's what computers do, is that they come up with their criteria of each cover. But if, then why do they have to do that? Well, because, while all 5 people may then currently then but if they're only going to offer 4, then they got to figure out the criteria. And so, with the reason that waiting times are a big issue in these studies, is because, that criteria is not really firm. It's hard to get a firm criteria that's going to separate out people who just need help, just medication and it's pain medication and talk about versus those who have need. Well, in this completely wrong about that because get money, you can get it done. If you don't have money, then you don't get it done. But other countries don't worry about it. So that's why it's waiting times is kind of the big issue in these types of countries. Because they, once you remove cost, once you remove the how much is going to be, the ability to pay for it, that then you have to figure out how to go through and devise care. All right, well, we're almost out of time. So on Tuesday, movie day, I'll send out the link and the information about the movie. And then the following week will be guest speakers and will be Zoom days. Good? All right.